to discuss about the essential of microwave perfusion imaging, stress, and pharmacological protocols overview. The aims of objectives are to know the different stressor agents, to understand the exercise and also pharmacological stress protocols, to identify the main indications of exercise and drugs tests, and to understand the flowchart stress testing for patients with coronary artery disease. How to do that? We have a lot of stress techniques. The goal is to detect myocardial ischemia in patients with coronary artery disease. We have a lot of protocols and techniques. The first one is exercise. Exercise by treadmill test or bicycle. However, sometimes need drug stress. For example, vasodilators with adenosine, dipyridamole, or the last one, regadenoson. And sometimes we can use a sympathomimetic drug called dobutamine. But of course, in some cases, we can couple exercise and drugs. For the exercise testing, normally, when you have an exercise, we can increase heart rate. You can increase blood pressure, and of course, you can increase contractility. What is very important because you have an augmentation of oxygen demand. And in normal coronary arteries, you can create vasodilation, and a very high blood supply is possible. In the case of the patient of coronary artery disease and stenosed arteries, the vasodilation dropped, and then you have a decrease in blood supply, and finally ischemia or infarction. The advantages of exercise testing are it's widely validated. It's very easy and cheap. And again, for cardiologists, it's very important because we can get what we call a physiological response. And we can provide also additional information. For example, the functional capacity, the hemodynamic response in terms of heart rate, in terms of blood pressure, symptoms, maybe you can have some chest pain, and sometimes on the ECG, arrhythmias. When to inject the tracer? Because in fact, it's just exercise coupled to nuclear medicine. This is when we can observe evidence of ischemia, chest pain, for example, symptoms, or some abnormalities on ECG. And for some patients, we have some what we call a target heart rate, which is very important because we have what we call an ischemia cutoff, which is 85% of the target heart rate. Then, the patient should continue exercising for at least 1 or 2 minutes after radiotracer injection. Concerning the drugs, we have vasodilators, adenosine, dipyridamole, and regadenoson. Depends on the half-time of drugs. And in some cases, we can administrate dobutamine. For the adenosine protocol, it's very easy. We need a syringe, and then we have adenosine and we have to start the infusion for 6 minutes. And at 3 minutes after the injection of adenosine, you can infuse the tracer injection, sestamib, tetrophosphine, or thallium. And then the end of infusion is 6 minutes later. Of course, in some cases, if you have some what we call adverse effects, we can administrate what we call an antidote. Antidote is aminophylline, and this is very important if the patients have some flush or headache or some fatigue. For the dipyridamole protocol, this is quite similar, just the duration of the administration is about 4 minutes. And we have to inject the tracer at 4 minutes. Again, if we have some adverse effect, we can administrate the antidote like aminophylline. This is a new one. This is what we call regadenoson. It's a very interesting drug because it's a selective adenosine A2A agonist. It's just one single bolus injection with no adaptation to patient's weight. And again, the duration is about 3 or 4 minutes. And the indication is in some patients with CAD, but also with some asthma or COPD. It's very important because in the case of you have asthma and COPD, the contraindication for dipyridamole or adenosine is approved. And also the antidote is aminophylline in case of adverse effect. But also regadenoson is a very expensive drug. So it's for that, in some cases we can use dobutamine. And dobutamine is exactly the same protocol as we can use in echocardiography for the stress echo, because it's different steps. So then we have to increase step by step the dobutamine injection. It's 5, 10, 20, up to 40. And then this is the increment every 3 minutes. The short half-life is very important again, it's 2 minutes. And the indication is for some patient with suspicion coronary artery disease and asthma or COPD. But the antidote is different because the antidote is beta blockers. And at each step is first of all to inject atropine just to increase the heart rate. So finally, for the flowchart stress testing depends on the patient we have in front. For example, if you have a patient with pacemaker, patient with left bundle branch block, then you have to decide to do drug, and mostly with vasodilator without ergometry. In some patients, if you have a patient able to exercise, so you have to decide to do and to perform ergometry, bicycle, treadmill test. It depends on your department. Why? It's because to reach the target heart rate, and of course then to infuse the tracer. In some cases, if the patient is able to make some exercise, but in fact not to reach the target, then we can couple exercise and stress by drugs. Of course, it depends on the contraindication of dipyridamole and adenosines. In the case, we can move to regadenoson or dobutamine, and sometimes just the couple vasodilator and low level of ergometry is enough to get the ischemic point. So to sum up, in fact, we have a choice. Stress testing is maybe exercise or drugs, or both. The recent vasodilator is very interesting for all the patients, obese patients with regadenoson. And in fact, it's very important to assess the best stress testing in regard of the patient, in regard of the BMI, in regard of ECG and patient treatment too. So then, the main indication anyway for stress testing is to detect myocardial infarction, to detect myocardial ischemia in some patients with coronary and suspected of coronary artery disease. So in conclusion, exercise is the first choice stress test. But sometimes, if exercise may not be performed, a drug test can be the second choice. And of course, you can make ergometry, drug test, and anyway, in terms of diagnosis, in terms of prognosis, this is a comparable accuracy in the literature. So, what is important for the nuclear physician is to make stress, of course, to detect ischemia. But to detect ischemia, you need a second step, which is rest condition. So finally, this is the stressed rest imaging, which is very important to detect myocardial ischemia. Thank you for your attention.